Welcome to this deep dive into question 21 from the orthopedics curriculum. We're going to break down three really key pathologies you'll see in the upper extremity. We're talking nerve entrapment, some common tendon diseases, and a fascinating fibroproliferative disorder. Okay, so here's our game plan. We'll kick things off with how to assess nerve entrapment. Then we'll get into diagnosing muscle and tendon issues. After that, we'll tackle Dupuytren's contracture. And finally, we'll wrap it all up with the clinical takeaways you absolutely need to know. All right, let's start with a core clinical skill. You are going to see nerve entrapment syndromes all the time. And remember, before you even think about ordering imaging, your first and most critical step is always a solid physical exam. So let's start with a foundational question. When you've got a patient and you're suspecting a peripheral nerve issue, what's a really primary, hands-on technique you should be thinking about to try and elicit those symptoms and figure out where the problem is? And the answer is percussion. Yep, just tapping. It's such a simple, elegant, and really effective way to get a rough assessment of the nerve. It helps you reproduce the patient's symptoms, which gives you a huge clue about where that irritation or compression is happening. Now, here we have the absolute classic clinical example for this. Assessing the median nerve, or the medianus, in the carpal tunnel, which is also known as the canalis carpi. Tapping over the spot to get that familiar tingling, that paresthesia, is of course Tenosynovitis. It's just the perfect application of this whole percussion technique. Okay, so let's move on to our next section. Now we're looking at diseases of the muscles and tendons. And for these, your palpation skills are what's going to be front and center in telling you what's really going on under the skin. And this slide just lays out the difference so clearly, right? It's all about what you can feel. With Tenosynovitis, you're feeling for that friction, that crepitation and clicking as the inflamed tendon struggles to move in its sheath. But with a complete rupture, you're feeling for an absence of something, a literal gap or defect in the tendon, which you then confirm with that obvious loss of function. So where should you be on the lookout for these ruptures? Well, these are the big ones, the high-yield locations you're most likely going to see in the clinic. Each one has its own classic story, its own mechanism of injury, and specific clinical tests, like the Thompson test for the Achilles, that you'll want to have ready to go in your diagnostic toolkit. Now, for our third and final pathology, the very unique fibroproliferative disorder known as Dupuytren's contracture. Now, this isn't an issue of a nerve or tendon inflammation. No, this is a primary disease of the fascia itself. So the most crucial point to get here is that this is a disease of the fascia. You've got these abnormal fibroblasts that just start to proliferate and lay down collagen, forming these nodules and cords. And that really explains its progressive nature and why it physically starts to pull the fingers into flexion over time. And you can see that whole pathological cascade mapped out right here. It all starts at a cellular level, deep in the palmar fascia. Then it becomes something you can actually feel, those nodules and cords. Eventually, that leads to the classic clinical picture, a flexion contracture, usually of the ring and little fingers, causing some really debilitating functional limitations. So when does the contracture get to the point where it's time to intervene? Well, it's all about function. For instance, when the patient can't place their hand flat on a table anymore. This table shows our main options, and they range from minimally invasive office-based procedures like a needle fasciotomy or an enzymatic injection with collagenase, all the way up to surgical excision for the more severe, complex, or recurrent cases. All right, we've covered a lot: nerves, tendons, and fascia. So let's boil all this information down into a few high-yield points that you can take away from this explainer and use as soon as you hit the clinic. So what are the crucial points? First, if you suspect nerve entrapment, start with percussion. Second, for tendon issues, let your fingers do the talking. You can feel the difference between inflammation and a full tear. And finally, remember that Dupuytren's is a progressive fascial disease, and the decision to treat isn't just about a nodule being there, it's all about the loss of function. And to leave you with a little something to think about, out of these conditions, nerve entrapment, Tenosynovitis, or Dupuytren's, which one do you think might be the most subtle, the hardest to diagnose before those really clear, definitive clinical signs start to show up? Think about how they first present and what might lead to a diagnosis getting delayed.